what I wanted to do first was go back to a bit of basics, really, and review a bit of the liver anatomy and physiology. I think it's really important when we're talking about the abnormal that we have an understanding of how things work normally within the liver. I'm hopeful that by the end of the session you'll understand the difference between liver enzymes and tests that actually measure specifically the liver synthetic function and how they're both important. Also understand the differences between abnormalities in hepatocellular, biliary excretion and cholestatic markers. We'll be able to list common abnormalities of liver tests and also consider the important follow-up tests that are necessary to diagnose different diseases of the liver. So going back to basics, the liver is an amazing organ. It's the largest organ and gland within the body. In a woman, it weighs around 1.3 kilograms, and a man 1.8 kilograms. It's covered by this thick elastic capsule known as the Glisson's capsule, which covers the entire surface of the liver. It's split into two main lobes, so you have the larger right lobe and the smaller left lobe, and then there's two further smaller lobes, the caudate and quadrate. It's further segmented into 8 divisions, basically, and each of those 8 divisions has its own vascular inflow, outflow, and biliary drainage. And the reason it can do that is because there's a branch of the portal vein, hepatic artery, and bile ducts within those segments. So with regards to the blood supply in the liver, well, you get dual blood supply, so around 25% of the liver's blood comes from the hepatic arteries, and around 75% is drained from the GI tract, the spleen, and associated organs. And the liver is holding about 1 pint of blood at any one time. You'll get oxygen provided from both sources because the blood coming in from the portal vein is actually partially deoxygenated. And it flows through the liver to the hepatic cells, and then blood drains out of the liver via the hepatic cells and into the inferior vena cava. If we look closer at the liver, you have the liver lobes, which are made up of these lobules, which are hexagonal in shape. And the lobules are the functional units of the liver, so they contain the liver cells or the hepatocytes. And about 75% of the liver is made up of hepatocytes, and these are your functional cells, the working cells. They have a number of jobs to do. They absorb nutrients and detoxify and remove harmful substances. They synthesize and metabolize some substances. And then between each row of the liver cells, you'll have the sinusoids. And these are cavities that have numerous cells within them that are responsible for removing amino acids, nutrients, sugar, old red blood cells, bacteria and debris. And again, next to the hepatocytes, you'll have the bile canaliculi, and this is where bile is secreted from the liver cells. It's important to note the biliary system as well, and this includes the gallbladder and the bile ducts that are both inside and outside the liver. And the main functions of the biliary system are to drain waste products from the liver into the duodenum, but also to help with the digestion and the controlled release of bile. So when the liver cells secrete bile, you get it collected by a system of ducts. These flow through the liver to the right and left hepatic ducts. The ducts drain into the common hepatic duct, and then that's joined by the cystic duct from the gallbladder to form the common bile duct. And this is where the bile runs from the liver into the duodenum. So about 50% of bile is stored within the gallbladder if you have one, and the rest will run directly into the duodenum. It's an amazing organ, as I've said. It has over 500 functions. Some of the really important functions of the liver: it provides immunity against infection, regulates blood clotting. It's a big factory for synthesis of proteins and cholesterol. It detoxifies, it excretes waste. And importantly as well, it converts glucose for storage as glycogen, which I'm sure Jill will cover quite in depth within her talk. And it excretes bile for fat digestion. And because there are so many functions of the liver, this is why it's particularly hard for there to be one test that tells you what's going wrong or how well the liver is functioning. So when we take that sample of blood, liver function tests, how does that actually reflect what's going on in the liver? And I think it's really important to say that interpretation of abnormalities of liver function tests are a real common problem for a variety of healthcare professionals, and also within hepatology as well sometimes. So what's the use of these blood tests? Well, they're fired off very easily. It's very easy to have liver function tests taken, routine blood analysis, routine health checks, insurance checks, if you're feeling a little bit unwell, vague symptoms, drug monitoring as well. In some cases, they can detect the presence of liver disease, and in some cases, they can gauge the extent of known liver damage. They are very useful at following up response to treatment, but they're rarely going to suggest a specific diagnosis. But they can tell you whether there's destruction directly to the liver cells, which is known as hepatocellular, or impaired transport of bile, which is known as cholestatic. So they can further direct your evaluation of the patient. They certainly have limitations, and liver function tests really can be pretty useless in a lot of situations. They lack sensitivity and specificity. As I've said, no single test reflects overall hepatic function. About 2.5% of the population, the healthy population, will have abnormal liver function tests. Up to 10% of persistent abnormal liver function tests will not correlate with any damage that's going on in the liver. So you can have somebody that's got very abnormal liver function tests for a long time, but they won't be putting any scarring down on the liver. And also, a very important point is that lots of patients who have cirrhosis will have completely normal liver function tests. So I'm going to look first at the serum transaminases. So they are the enzymes within the liver. So you can categorize these enzymes. As I've mentioned before, those that are elevated in serum, which are reflecting damage directly to the hepatocytes or the liver cells. Those who are elevated in serum reflect cholestasis, but also you can have a bit of a mix pattern as well. And you'll all be used to seeing these as part of liver function tests. So you have your alanine aminotransferase, which is your ALT, your aspartate aminotransferase, which is your ALT, your alkaline phosphatase, which is your ALP, and also gamma-glutamyl transpeptidase, which is your gamma-GT. And so these can help to categorize the injury patterns. They can be a sensitive indicator of liver cell injury, and actually probably they're most useful when you have an acute event going on. And as I've said before, they correlate very poorly with hepatic injury in chronic conditions. So if I look at injury first directly to the liver cells, well, some of the common problems and the causes of this injury are things like viral hepatitis, steatosis or steatohepatitis, so this is fat causing inflammation within the liver, autoimmune liver disease, which we see, and various toxins and drugs as well. The most specific test in these situations is the ALT, because this is found primarily in the liver. We also use the AST, and this can be elevated, but it's not as specific because you find it elsewhere. So you'll find it in cardiac muscle, skeletal in the kidneys, brain, pancreas, and lungs. I've put the normal reference ranges up there just for your reference, but again, you can have significant liver disease and these levels can be normal. You can also use some of these enzymes to work out a bit of a calculation, so the AST divided by the ALT, and in some cases, this can let you know if a patient is likely to have fibrosis. So scarring of the liver occurs when you have repeated injury to the liver. If we look at cholestasis, so this is a condition where bile cannot flow from the liver through to the duodenum, and it might be due to the hepatocytes not working properly, so you get impaired secretion, or also due to obstruction of the bile flow, either through the intra or extrahepatic ducts. So some examples: extrahepatic duct obstruction, where you might have gallstones or post-surgical strictures. You can get autoimmune conditions such as primary sclerosing cholangitis, which cause intrahepatic duct narrowing, and also another autoimmune condition, primary biliary cirrhosis, which causes damage directly to the bile ducts. And this is best sort of investigated or best seen through a raised alkaline phosphatase. And the reason for that is because bile acid stimulates alkaline phosphatase production, and the damage will prevent that excreting into the duodenum. So the alkaline phosphatase within the serum will rise dramatically. It's found in the bile canalicular membranes of hepatocytes, but again, it's also found elsewhere. So things like bone, kidney, placenta. So you've always got to be thinking of a differential diagnosis in patients. What you can use the gamma-GT for, now the problem with gamma-GT is, again, it's not very specific. It's found in the bile duct epithelial cells. Traditionally, people have really linked this to alcohol misuse. So massive problems, say, with the DVLA over the years, who will stop people who might have had their license taken away for a drink driving event, but then getting that license back. It used to be that you had to have normalization of a gamma GT, but there are lots of other reasons why your gamma GT will be raised. If you have non-alcoholic fatty liver disease, that will put your gamma GT level up. So it's not associated with alcohol injury alone. It can be useful in following patients up who are alcohol abstaining when they've had a very high gamma GT through very high intake of alcohol. But also it's quite useful to confirm if your raised alkaline phosphatase is coming from the liver rather than bone. So if you've got a raised alkaline phosphatase and a normal gamma GT, you may be looking for alternative diagnosis. Talking about markers of synthetic function, so your enzymes are there in response to injury if they're going up, but also what we want to know is, are there any blood tests that tell us if the liver's not working properly? And one of the best markers of that is albumin. This is solely synthesized by the liver, and it's a good marker to assess chronic liver injury rather than acute. And so you'll see a low serum albumin in patients with severe liver damage and potentially ascites. The problem with all of this, however, is that because the liver is such an amazing organ, you only need about 10% of the liver to be working in order for it to do its functions properly. And therefore, by the time you've got a liver patient who's dropping their albumin, things are, really late on, and it's a bit too late to be considering these things. So it illustrates late disease, but again, differential diagnosis. It can be affected by other factors such as poor nutrition and kidney disease. If we look at bilirubin, so this is another good marker of synthetic function, so the breakdown of red blood cells, and you get it in two forms, either conjugated or unconjugated. I've put the normal range there. If you're looking at somebody who's jaundiced, they would probably need to have a bilirubin level of greater than 50 at least for you to be able to see obvious signs of jaundice within them. You get three types of jaundice. So you'll have prehepatic, which can be caused by hemolysis. Gilbert's is a benign liver condition which causes excess unconjugated bilirubin. Intrahepatic, which, for example, is caused by things like viral hepatitis, when you have cirrhosis, alcoholic hepatitis, drugs, hepatocellular carcinoma, and also posthepatic jaundice, where you've got things like gallstones, pancreatitis, pancreatic cancer, etc. So it's quite a sensitive test for liver dysfunction. You can see jaundice quite a lot in acute problems with the liver, and in those cases it's normally transient and the patients will get better. The other measurement of synthetic function of the liver is to look at blood clotting factors. So the liver synthesizes all factors concerned with blood clotting. If you get a decrease in the concentration of plasma clotting factors, you'll find this in impaired liver function. So what we look at sometimes is the prothrombin time. So this is a simple measure of the liver's capacity to synthesize clotting factors. The normal range is about 10 to 15 seconds. If that's prolonged, and certainly if that's prolonged by greater than 5 seconds, it's a poor prognostic sign in both acute and chronic liver injury. And we also look at the INR, which was brought in to standardize the prothrombin time. And again, patients with advanced liver disease will have a raised INR. I think, for me, one of the most important things about looking into liver disease is how we talk to our patients and the information that we glean from our patients. So patient history is absolutely vital. Common diseases are common. As Andy's mentioned, the common diseases are alcohol, fatty liver, viral hepatitis. So we need to consider risk factors for fatty infiltration, obesity, diabetes, hyperlipidemia, hypertension. We need to look for risk factors for viral hepatitis, so intravenous drug use. And with things like intravenous drug use, even if people have used once 30 or 40 years ago, who may not really want to divulge what they did as a student, that's a transmission risk. Sharing of tourniquets is a transmission risk, tattoos, piercings, blood transfusions before 1991, foreign travel for things like hepatitis A and B, cocaine snorting, so intranasal drug use as well can be a transmission risk, and also maternal transmission, so transmission from mother to baby. And really talk to people about their alcohol. And again, for us, it's not good enough just to say, Do you drink alcohol? No. All right, carry on. You really got to get to the nitty-gritty of people's alcohol history, when and where they drink, have they been in problems with the police, etc., to try and get a proper patient history. We have something called a non-invasive liver screen. So if somebody has an abnormal liver enzyme, they may well go on to have this screen. And this includes testing for viral hepatitis, hepatitis B and C, and we also test for HIV because all these disorders are blood-borne. They're transmitted in the same way. So there's no point in testing for one. If you're going to look after that patient properly, you need to test for all three. If it's an acute picture, you'll look at other viruses that can affect the liver. We look for autoimmune liver disease, and these are becoming much rarer now. They're not our main contenders, but they do occur. And we have genetic disorders where you can have iron overload, hemochromatosis. So we monitor ferritin and iron studies, and other genetic conditions, alpha-1 antitrypsin and ceruloplasmin, which is Wilson's disease. Just wanted to talk a little bit about a case example. So this is somebody that I saw in the liver clinic in the summer of last year, 53-year-old, ex-intravenous drug user, had given up 18 months ago. All our patients in Cornwall that are under drug and alcohol services will have yearly viral hepatitis screens, independent of whether they're still actively using. And so we knew with this chap that in 2014 he'd had a negative viral hepatitis and HIV screen. He went yellow and got a bit feverish, and so his GP referred him in. But other really than feeling a bit feverish, he felt very well. Took methadone 60 mils daily, but no other medications. And he reported that his partner, who was still using, his story was that he was clearing her sharps away and had given himself a needle stick injury. So you have that transmission risk. But really this is to highlight what happens with blood results. So it's an acute picture. His ALT was over 1,000. Alkaline phosphatase was raised as well. He had a normal albumin, so the liver's working properly. And he also had a raised bilirubin, so he was jaundiced. And that was the 8th of June when I first saw him in the liver clinic. This patient doesn't need admitting into hospital. He had weekly bloods taken with a GP. And even in the space of around 2 to 3 weeks, you can see that his liver numbers have pretty much normalised. So things can be really bad, but can get better very quickly. And he did have acute hepatitis C. And it's quite unusual to pick up acute hepatitis C because lots of people, when they catch hepatitis C, have no symptoms, or they have very vague symptoms that you put down to, I've got a cold, I'm a bit tired, I'm working too hard, I've got too many children, I'm getting a bit older, I've got diabetes, it's that medication. And that is often what happens with liver patients. They either don't get symptoms or they get very vague symptoms that would not lead them to report that to the GP. He was lucky, this chap, so in December I rechecked his hepatitis C and he'd gone negative. So he was one of about 25% of people who will spontaneously clear the virus. And he was a little bit tired, but he was getting much better. So when you're looking at an acute picture, as I've said before, you think of the other viruses. There's also viruses from the herpes family, so Epstein-Barr virus, which is commonly caused of glandular fever, cytomegalovirus. These can cause an acute hepatitis. Drug-induced liver injury is important as well. So again, when we're asking patients about what drugs they take, it's not just prescribed drugs, it's recreational drugs, it's over-the-counter remedies, herbal remedies, things that people buy over the internet. And drug-induced liver injury can occur with things like paracetamol, and this is intrinsic. So if all of you sat in the room this morning and took 100 paracetamol tablets, you'd all be in problems. But also idiosyncratic. So there are things like amoxicillin, which, how many prescriptions of amoxicillin are fired out? It's a very common drug to prescribe. And by idiosyncratic, I mean you've got non-steroidals up there, anti-epileptics, herbal and dietary supplements. So this occurs a bit rarer, and also we don't really understand why some people will have a reaction and others won't. But it's really important to get a good drug history, at least going back 12 months. This is another case example. This is a 68-year-old who came up not that long ago. We have a liver hot clinic. So myself and 2 consultants rotate a rapid access clinic for patients who have decompensated or there's a likelihood that they have cancer. And from about the 2 months before I saw him, he'd had rapid weight loss, started to get some tummy pain. his GP had sent him for an ultrasound, and this had shown a solitary 9 centimetre mass within the liver. And up until prior to that 2-month period, this chap has comorbidities, but again, he'd been feeling very well. He'd been getting on with his normal life. When I look back on his bloods, he had an 8-year history of having an abnormal ALT, so in the region of about 80 to 90. He had a history of diabetes, high blood pressure, high cholesterol, and was overweight, so all the risk factors for fatty liver disease. With the ALT, when I look back as well, it started improving the sort of 2 to 3 years prior to seeing him. And Andy's slide at the beginning of the cirrhotic liver, what happens when you lay down scarring of the liver is that you replace your disease process with the scarring process. So things get better. So, and I'm sure we're not alone in Cornwall. Commonly what happens is a GP takes a liver function test, it's abnormal, what shall I do? I'll repeat it in 3 months. And it gets repeated and repeated and repeated. And then, oh, it's getting better, great, we don't need to do anything. But actually the patient's getting worse. We took an alpha-fetoprotein, so this is secreted by some liver cancers, and it was massively raised at greater than 2,000. So this chap had a diagnosis of non-alcohol-related steatohepatitis, which had caused cirrhosis and a large hepatocellular carcinoma within the liver. He's 68 years old. Because of the size of his tumour, he's outside transplant criteria, and it just illustrates the misunderstanding of liver function tests. And I'm sure that Andy and Phil and lots of other people in hepatology, this is quite a common occurrence with referrals. And it's really hard to talk to these patients because they can't believe it. They can't believe they've gone from feeling so well to being, you know, in this position where really there's very little you can offer them. And they question very much, why was that not picked up 7, 8 years ago? Why did nobody do something about it? So I think we all have a responsibility, not just within liver disease, when we're looking at blood tests, to refer. So what's the way forward? Well, the way forward is us in the liver community getting up and shouting about the problem of liver disease and what's happening today. And actually, we talk a lot within ourselves, but we're preaching to the converted. And the most important things are things like today, our allied healthcare professionals, all the other people that will come across patients with liver disease and increasing the awareness and educating there. And that will bring about change, because what we don't want to see is that 68-year-old gentleman. We want to see and be intervening with these patients right at the start, decent weight loss, decent management of diabetes, and stop them getting to a point where it's completely irreversible. So just to summarise, if you're looking at a raised ALT, it's most likely coming because of injury direct to the liver cells. Raised alkaline phosphatase is normally because of a cholestatic cause, but remember differential diagnosis. Is it isolated or persistent? So if I'm sitting in clinic and I have a referral to clinic, this chap's got an abnormal ALT, the first thing I will do is look back to see the pattern. And you go back as far as you need to go back. You know, is it a one-off? Is it simply because they're a little bit overweight or they're drinking a little bit too much booze? You lose weight, you stop drinking, everything normalizes. They're probably unlikely to have problems with advanced liver disease. You know, are they on certain hepatotoxic drugs that you take away and things go back to normal? Gamma GT, as I've said, is not very specific, but it's good to isolate whether a raised alkaline phosphatase is coming from the liver. And if you have a low albumin, if you have thrombocytopenia, if you have jaundice and abnormal clotting, they are all indicators that you've got advanced disease, so advanced cirrhosis. In raised bilirubin alone, because this is another thing people often refer with just an isolated bilirubin, Gilbert's is a very common cause. It affects a lot of people. You just have less of an ability to clear bilirubin from the system or bile from the system. And there are very helpful liver function test pathways in existence. It just tidies things up a bit and lets people know who aren't specialising in liver disease which way to go and which way to investigate abnormal liver function tests. So there's no clear-cut picture in interpreting liver function tests. There's no answer, one-word answer to it all. It is based liver disease management on a variety of tests, be they biochemical, serological, sometimes we rely on histological, so do liver biopsies, and talk to the patient. That's just, for me, the most vital thing is the patient history. We're also getting a real increase in what we call non-invasive fibrosis methods. So we don't have to put patients through invasive procedures such as liver biopsy all the time. There are much nicer ways of seeing if people have scarring of the liver and getting to them before they get to the point of cirrhosis. So there's a much greater need overall for identification of liver disease, for diagnosis and earlier intervention and treatment as well. So thank you very much for listening to me today. I do appreciate it.